I'm also finding out that where all the really big homes on Legacy Ridge are now, that's all built on a dump. Like that used to be a dump, and there's still big vents coming out to the side of Liberty Lake where they covered up all the garbage, but they still have to vent the methane. Pretty. It's just ironic that all these $1 million homes are built on
garbage.
the dump. Exactly. You guys give Trevor a hard time because he lives in some castle somewhere.
But he doesn't. He looks like a paranoid method. He has this little cabin with all these cameras that he monitors during class.
What? In the South Hill?
Just like a lot of land in South Hill. Yeah.
I don't know what Hilliard means.
Take Green Street and keep driving north.
Culture shock.
Okay.
It's a good neighbor next door house.
It's nice.
I'm-
You've got a nice security system, huh?
Yeah. After I had to install it.
I see.
Did your security system cost more than your house?
No, but yeah, as I was looking at it, I could have easily seen it.
When you say had to, though, your insurance company said you have to do it.
No, it was after the first break-in.
After the first break.
Have you changed tires on your house yet?
Here, I'm going to push pause on this recording real quick. Back to the lecture. Now I wasn't going to finish the sucker in that time. What was I thinking? Yeah, that's an ingenuity right there. Chris, what are some other tricks of the trade? I see. I see how it is. But really, why would you steal a phone anyway? Like phones nowadays, like you can't get into them, you can't use them. I can from the outside just delete everything and like turn it off. I don't see what the purpose is.
I've had a similar story where we didn't track the phone down, knock on the guy's door. We were debating between which house it was.
Yeah.
Knock on both doors. And then finally, we had to share it with us.
Oh, really?
Yeah.
Nice.
Well, let's go find him.
Oh. And did the sheriff like
He was
arrest him, fine him, anything?
No, but what was bad about it was when the guy answered the door, it's like they knew each other.
Oh, seriously?
He's like, oh, what the hell are you doing here?
Oh, that's awesome.
It's a pretty good story.
What are you doing here?
It was my good buddy. He doesn't have the phone.
No, the sheriff was help out. He's not a thief. There was 3 ladies there, and we were out at the bar the night before, so.
This story keeps getting better. So he grabbed the wrong phone.
Yeah, what it was is I took a brand new phone, had it probably 2 days, stuck it in my coat jacket, threw it on the bar stool, and then someone knocked it over and or something picked it up.
I see.
And then that was.
All right, but he wasn't stealing it.
Well, I don't think it was him. I think it was
One of the ladies. That's awesome that you would say one of the ladies. All right. Goals of 12 lead acquisition. So in getting a 12 lead, this is kind of things you want to do to optimize getting a good 12 lead, because it's not, as you guys probably know, it's not always easy. So you want a good steady baseline, right? Not moving around, not a whole lot of artifacts, patient's not moving. You want it to be accurate, so the leads need to be placed correctly, and you want to be able to do it in a timely manner. You want to make sure that the distortion is non-cardiac, and how you can adjust and fix that. Causes of artifact: loose electrodes, broken cables, wires, tremors. That 60 cycle interference, and what is that again? Yeah, it's electrical. Why they don't just call it electrical interference, I don't know, but 60 cycle is probably some kind of something to do with physics and electricity, whatever.
We run at 60 hertz.
Is that what it is?
Our electrical grid.
Well, there you go. Thanks, Craig. All right. Muscle tremor is obviously going to be a big artifact. So how do you reduce the artifact? So you want to make sure that you've got good adhesion to the skin. Remove hair. You guys have clippers or anything like that? You have razors? So dry razor on chest hair does not work at all, and just like basically you're just ripping out hair. So the pads would probably be a lot better.
I think my buddy will give me his costume.
Relatively, yeah. Man, dry razor. That sounds awesome. So skin prep, remove the skin, remove the skin. Yeah. Try to get rid of the dead cells, skin oils. You know, some patients are not going to be as hygienic and haven't bathed as much, and it's just dead skin, and you got to kind of scrub them a little bit. Use alcohol swabs. Use a brisk dry rub. I thought that was kind of a funny line there.
Use of alcohol swab is not recommended. Why is that? Alcohol must put gel or...
Well, because electricity and alcohol is oftentimes bad combo. Especially when you're using pads.
Yeah.
Not as much with leads, but you could still maybe burn the skin a little bit. Obviously, it has happened, or it wouldn't be suggested. So your second goal, you want it to be accurate. You want to make sure that your electrodes are placed correctly, position the patient well, so you can get a good tracing. All right, so frequency response is just kind of helps you kind of define accuracy on obtaining an EKG. If you're looking through a window, are you going to be able to, all right, I shouldn't even say looking through a window, are you going to be able to reproduce your EKG multiple times? And if you can, then obviously that was an accurate EKG. All right? And we'll talk about this narrow and wide. So a narrow frequency response, so you're not allowing the monitor, or you're tracing, you're recording to see much of the artifact. So that it's helpful when determining the rate and rhythm, but not necessarily for the waveforms. It doesn't give you the most accurate waveforms, but it does give you good rate and rhythm. The wide is when you're going to get good diagnostic quality. So you're going to want this to get good ST segment analysis. But of course, if you with wide in obtaining a 12 lead EKG, you're more prone to pick up what? Artifact, right. So your frequency response diagnostic quality, you want it to be between 0.5 hertz to 150 hertz. Speed of the EKG, you see down there at the bottom, it gives you the hertz, it gives you the speed, millimeters per second, and it gives you the calibration, right? So you can always check that stuff to make sure that everything's accurate. What kind of frequency response do you think that is? This, I need to move this thing. So this is on a 30-year-old. And can you see what's wrong with this patient? Where's your abnormality? This is V1, by the way. So while this was hooked up, it was changed from, do you guys know how to change the frequency response on the EKG? So you can change it, but it was changed from monitor quality to diagnostic quality. Depending on what you're trying to see. So if you're really trying to figure out what the rate and rhythm is, then monitor quality is great. Diagnostic quality is when you want more specifics. So if you're printing out a 12-lead EKG, generally you want diagnostic quality, where you can make out waveforms and see. This patient has ST elevation.
Yeah, because I kind of see two areas on that, like 2, 3, 4.
Right. It almost looks like.
Like a switch device or artifact.
Right. So you've got more artifact in the beginning when it's in monitor quality. And then you can see where it switched, where you have all of those squigglies there towards the end. And then you've got diagnostic quality, where you don't have as much of this artifact stuff. So this is monitor quality. Of course, can you see? I think you can still pick these up, but what's this rhythm? Okay, maybe you guys can't pick this up. Do you guys see the pacer spikes?
Oh, yeah.
Now they're very, very small because it's in monitor quality. But otherwise, if you didn't switch it so you can make those more obvious, you might not see them, and you might totally miss that the patient has an internal pacemaker, right? So they're being that's a ventricularly paced rhythm.
I don't think pace the atria. Like that's a really rapid rhythm. Maybe you're putting something in there.
Well, different pacemakers do different things, but this is most of your, I guess, older pacemakers are single chamber and they're ventricular paced. The newer ones are dual chambers; they'll pace both. But it depends on what your conduction system is. So if you try to pace the atrium, but you have a block to the ventricle, then you're not going to be pacing the ventricle, right? And you'll be pacing your atria. Your atria will go off at whatever you set it to. Then your ventricle will still go off at what? 20 to 40. So.
But they can do both, right?
They can do both now. There's dual chamber, and a lot of the pacemakers that you'll see nowadays are dual chamber, where you see the lead go into the atria and another one go down into the
And
ventricle.
how clean can we get that rhythm to look? Does it look almost normal?
No, it won't look normal because the ventricle will still look what?
Why?
Yeah. It'll still look like this. You'll just see an extra pacer spike with a P wave. All right, so there, when it was switched to diagnostic quality, see that? You don't have any artifact in this one, but you also don't see the pacers. Switch it to diagnostic quality, you start to get more artifact, but you can see the pacer spikes. Calibration, We already talked about the calibration and how you can see those boxes. You guys understand calibration and what it needs to be at. All right. Twice normal. Paper speed, we talked about that, 25 millimeters per second. So obviously the speed of acquisition is important, how quickly you're able to get an EKG. So it's going to be important. You guys know your anatomy, and obviously once you get experience, you don't have to count everything out, find all the intercostal spaces. You guys can stick those leads on and get an EKG quick and in a timely fashion. Sometimes in really sick people, you want to get that EKG before the ARS, right? So you can find out what your cause of origin is, right? So, yeah, you're removing the patient's clothing. Sometimes clothes, just buttons, metal buttons, those kind of things can cause artifact and cause issues. So we talked about this before. Beats in a horizontal row are continuous, even as the leads change. So all the way across, the horizontal beats are continuous. And then your vertical beats are matching up. Now they won't always look, obviously be in the same amplitude or anything like that, depending on which lead you're looking at, but the beats will match up vertically.
I thought across horizontally, you were looking at, like, for instance, this rhythm, same two beats in the different leads. Like
1, 2, 3, 1, 2, 3.
Right. So you're looking at the same beats in different leads, but the machine puts it together so that it is continuous. It's in that 2.5 second sections, but that you could still count off or look here to see if it's regular or irregular. Now, of course, you're only looking at 2.5 seconds, except for this one down here. But you can still see it. It's repetitive. Yeah.
If you're looking at lead 1 and lead 5, are those done at 2 different times, at the exact same time, and just put together on paper?
Exact same time. Wait a second. Oh, that sounds
Yeah, because I know the bottom one is one continuous.
right. The bottom is one continuous. It might be.
Matchup. So I guess you can.
No, yeah. You're sorry. I'm wrong. It is. I mean, it's 2.5 second sections, but it is, I guess, over time. So the whole strip is longer. But yeah. So these two beats are not identical to, say, those two beats. It's not at the same time. It's over time. Okay. So sorry, my explanation before is wrong.
So like a PAC and lead 1 that you wouldn't see it as beat.
Right. It's not going to be mirrored in all of the leads. It'll be over time. Exactly. So it's not the exact same beat. Otherwise, it would be impossible to tell anything, at least from a rate and a rhythm standpoint. It really has to be over time. All right. So yeah, you always want to make sure that your equipment looks good, right? You're using fresh electrodes, checking your wires, your cables. Patient movement. You have a wandering baseline. You guys have asked about that before. The baseline kind of wanders around. That oftentimes is because of movement. And if you do have a wandering baseline, it's really hard to tell if there's ST segment abnormalities. You can't, you don't know where the J point is. It's hard to, so you need a good baseline. If there's tension on the cables, you guys have probably done this when you're putting higher leads on, you're trying to get an EKG, and you're like, what the heck's going on? If there's just tension, so if it's pulling on the skin, if there's tension on the cable, it'll give distortion and artifact and can cause the baseline to wander as well. So that cable, it needs to be relaxed, right? Just having the getting a good EKG while you're moving is difficult, not always accurate. So if it's between, you know, and it probably takes what, a minute to pull over, maybe a little bit, maybe longer than that, depending on where you're at, to pull over and get a good EKG. But if you're wondering on whether or not this is going to be a STEMI alert or not, then that's probably worth it to have the cath lab ready when you get to the hospital, right? So your interference. Make sure that there's not other power cords. This happens at the hospital a lot because there's power cords all over the place. They're on a bed that's electrically controlled, so there can be a lot of issues there with interference. Just having the patient's phone. Sometimes the patient will, you know, have their phone in their hand or whatever, and that can cause interference. All right. Do you guys work with MCL at all? Have you guys ever heard of this before? Okay. So you guys get EKGs all the time as EMTs, right? You're getting them for the medics. You're setting it up. You're putting the leads on. You've never heard of the MCL 1, MCL 6. Okay. Then, because I was wondering about this, and I'll talk to Doug about it, but I don't think that this is something that you guys need to know.
You do it using Portland cables.
Yeah, if you don't have a 12 lead, you can do it with 14.
Yeah, so that's kind of the point.
It's going to be slightly different than you're referencing off the left arm instead of the center of the arm.
Yeah, exactly. Well, see, then you do know what it is.
I read it last night. That's the only reason why.
I see. So yeah, this is a way to get basically a 9-lead EKG. If you don't have a 12-lead, you can use this technique in order to get more leads or get more, I guess, views of the heart. Obviously, it doesn't give you as good a view as a full 12-lead, but I'll talk to Doug about it, and we'll find out if that's something that he wants you guys to really know, to learn, or not. I mean, you'd be a rock star if you didn't have a 12-lead, but you understood this concept and were able to get a 9-lead with what you had. But it's not something that you're going to have to do very often. And if you don't do it very often, you usually forget how to do it, even if you learned it at one point, right? So you'd need to look it up. Yeah, it was more common back in the day. Questions? All right. You can take a quick